Really excited to talk about priority two related to CMS's framework for health equity. And I know health equity is really something that I think has stymied the industry. We think we know what it is, but there's still, it's still something that's really being sorted out. And, by going through these priorities, I think it's so important because it will help us, right, better address some of the things, some of the key characteristics that CMS is asking us to do. And so for priority two, it's about assessing causes of disparities within CMS programs and addressing inequities in policies and operations to close gaps. And what I like about this one is I think that it is really wide reaching. I think about, during COVID, one of the things that I was with a medical group at the time, and we stood up a telehealth program within just a couple of weeks, about 3 weeks time, of learning that we could see patients telephonically with video, of course, if it's for risk adjustment. And one of the things that we found is that a lot of folks were eager to engage with us, and they had smart devices, but what they didn't have was broadband. And so I think that's a really good example of illustrating where there are disparities that a lot of times the best of intentions miss or were unable to address. And I know that not having broadband access was on CMS's wavelength as well. It was something that they had identified in later conversations. And so really this priority is around, how do we understand those types of disparities, uncover them quickly, and then address them. And I think that there were lots of programs that spun up outside of or from that experience, right, where folks were providing devices to members, or even other programs where they were using, say, paramedics and other health and community workers to drive out to certain locations and use their devices, right, in order to connect people to the healthcare that they needed. And I think COVID was a really great example of really putting the light on, or, ramping up the microscope, right, on what was going on and what we see. And we've been seeing over time, right, that really has been something that's challenged our healthcare system. And so, when I think about using data to discover disparities and address inequities, it's really it's going deep into that data. And I know I've said this in other sessions that we've done, but not accepting the data for what it is, but really trying to dig deep and understand what's beneath that data and what's causing some of the numbers that you're seeing. Don't take numbers at face value. There's lots of models out there to evaluate. I like to use the CIPP program. It's a particular way of breaking down programs and evaluating them, and it allows you to evaluate in different ways. And again, the acronym for that is CIPP. Maybe we could do a longer session on that at another date. Other models that you might consider using, and I know a lot of times we think, oh, we're too busy to do anything formal. I don't think it's something that's really difficult to get off the ground, but using, just a PDLC or an SDLC framework is great. So a plan, do, study, act, where you plan for something, you actually implement something, you study it to look for how it's affecting, and then you apply any types of interventions or changes to those interventions that you may need to do. And that's part of the assessment, and then repeating those cycle. And so I think that those are all good things that we could incorporate into our programs, whether it's specific to the technology that we're using, or even just operational efficiencies that leaders might use to make sure that they're addressing health inequities and making sure, right, that health is equitable for all our patients and all our members.